Hello class and welcome to the channel Clinically Speaking. This is part 2 of the video series on approach to hemoptysis. So now let's focus on the management of hemoptysis in this video. So the most important question that you need to ask yourself is whether you are dealing with life-threatening hemoptysis, and there are two ways that you can decide that. First is based on amount. So if there is more than 100 ml of blood expectorated per hour or more than 150 ml in last 24 hours, then you are dealing with massive hemoptysis. This is the definition which is based on the amount. But it is fallacious for two most important reasons. First is quantifying the amount is difficult. Second is even small volume of blood in somebody who has a cardiorespiratory disease can be fatal, and in that scenario you might underestimate the risk associated with hemoptysis. The more practical approach to deciding whether it's life-threatening or not is based on vitals. So if a patient is tachypneic or has low blood pressure, tachycardiac or has low oxygenation, you are dealing with a patient with life-threatening hemoptysis. So let's begin with the management of life-threatening hemoptysis. Once you encounter such a patient in casualty, there are three things that you should keep in mind. First, I have to stabilize this patient. I have to stabilize the vitals. Second, I need to find what is the source of bleeding. Where is the blood coming from? Third, you have to see what is the definitive treatment that I can offer to the patient. Obviously, in the emergency, you are going to start the patient on oxygenation, maintain a saturation of more than or equal to 92%, secure an IV access. While you are putting IV cannula, simultaneously collect the blood samples for CBC, LFT, QFT, PTRNR. Inject tranexamic acid 1 gram stat. If the patient is low on blood pressure, start IV fluids. Inquire about the intake of antiplatelets, anticoagulants or NOACs. And in the meantime, give a call for chest x-ray. Chest x-ray is something that you can get in emergency bedside and comes very handy because it can tell you whether the lung is abnormal or not and which side of the lung is abnormal. Because suppose if the right side of the lung is abnormal, it could be the source of bleeding. You have to make the patient lie down on the right side with the bleeding lung down. Now once you get a chest x-ray, there are three situations, there are three scenarios that you might come across. You might find a normal chest x-ray. Now there are two caveats here. First, sometimes smaller lesions can be missed on the chest x-ray and CT is more sensitive to pick up those smaller lesions. For example, something as small as a tumor like carcinoid or a bronchiectasis or a small aneurysm, that won't be picked up on chest x-ray. Second, the problem might be in the airway, and airway lesions such as endobronchial tumor cannot be picked up on chest x-ray. The chest x-ray can show you something like a unilateral lesion such as a mass in the right lung. So this can give you an etiology, and in this case it gives you a side. So the right side is abnormal, so you have to make the patient lie in the right lateral decubitus. You can also find something like a bilateral haziness which can point to a systemic disease. So patient might be having pulmonary edema or diffuse alveolar hemorrhage. So here you have to focus on the systemic causes, correction of the systemic cause of bleeding. So that's how a chest x-ray can help you in the emergency setting. So after taking these basic measures in emergency, you find that the patient is still tachypneic, has got lower blood pressure, low oxygenation, the patient is not stable. So the next step is to intubate the patient and secure an airway. The most important thing to keep in mind when you are intubating the patient is to choose a larger size single bore ET tube. So an endotracheal tube that you choose should be at least minimum size 8 and above. So the reason for that is ET tube with a bigger size will help you with suctioning out the blood and removing the thrombus. Secondly, you can do a bedside bronchoscopy. So if you choose a ET tube with size 6.5 or 7, that will not allow the bronchoscope to pass through the lumen. So you will be stuck. What you have to avoid, so if your patient is in respiratory distress because he is undergoing hemoptysis, don't put him on NIV with a full face mask. You are going to increase the risk of aspiration. The main cause of death in patient with a life-threatening hemoptysis is spillage of blood into the normal side. This leads to asphyxiation and impairs the ventilation of even the normal side of the lung. This is what we have to prevent. So save the normal lung. And that's why knowing which side of the lung is abnormal is so important. Save the normal lung, save the non-bleeding lung. This is the mantra of treating patient with hemoptysis. And for that you need to visualize where is the bleeding coming from, which segment, which lobe is the bleeding coming from, and for that you need to do bronchoscopy. Bronchoscopy is something like a long flexible tube, two light source, a camera and a suction channel through which you can pass small catheters and do some intervention. So it is long enough and flexible enough to allow you to visualize till the third or fourth generation of the tracheobronchial tree. The bronchoscope can be passed through an endotracheal tube as you see in this video, and that's why it's important to take an ET tube of at least 8 size or above. So by now we understand what could be the role of bronchoscopy. You can perform it in an unstable patient bedside. You can identify the site of bleeding. You can even control the bleeding, facilitate clot removal. So this is done best when the patient is having active hemoptysis. If the patient says I have mild hemoptysis, streaky hemoptysis 2 or 3 days back, then there are more chances that your bronchoscopy can be negative. But if the patient has active hemoptysis, you have the best chance of picking it up by doing a bronchoscopy. How can you treat the bleeding? Once you have seen, okay, it's coming from this segment or it's coming from the right middle lobe segment, how are you going to treat it? So you can instill ice saline, which is at 4 degrees Celsius at least. You can instill epinephrine. You can instill tranexamic acid. Or you can do something like a balloon tamponade, use a balloon blocker and use a local thermal ablative therapy like laser, APC or cautery. Let's know more about the last 3 modalities that we can use while doing bronchoscopy and control the bleeding. Now you might say that in casualty or in our hospital, we do not have Fogarty or we do not have balloon blockers, then how do we manage a case of hemoptysis? So what you can do here, again the mantra, save the normal lung. So here the patient is bleeding from the left side, left bronchus. You can pass your endotracheal tube through the trachea into the right main bronchus and inflate the cuff. Now what will happen? You have secured 2 important things. First, you have secured ventilation of the normal lung and you have inflated this cuff. Now this cuff will not allow the spillage of blood from the left lung into the right lung. So you have saved the normal lung or the non-bleeding lung. If you have a balloon blocker at your hospital or a Fogarty catheter at your hospital, then you can put the endotracheal tube in the trachea, place the tip above the carina, and pass a bronchoscope through the endotracheal tube, and through the bronchoscope you can pass a Fogarty catheter. It has got a balloon at the distal end. So once you have reached the left main bronchus, you inflate the balloon. By inflating the balloon, you have occluded the left main bronchus and now the blood from the left side can't spill into the right side. So you have again saved the normal lung. So this is how a Fogarty catheter looks. So there is a balloon mounted at the distal end of the catheter and you can inflate it. It is available in different sizes, 5, 7, 8 French. And this is how an endobronchial blocker looks. To a Fogarty catheter, but it has got a latch, a string at the distal end. So there is a string at the distal end and you can pull this string to tighten it around the bronchoscope. We will see how to use this endobronchial blocker. So now coming to case example, here the patient is bleeding from one of the segments. So we can see here. And now we have to stop the bleed. For that we can pass this thin Fogarty catheter through the bronchoscope. Once the catheter has reached the bleeding segment, we can push air inside the catheter, inside the balloon and inflate the balloon. That will occlude the bleeding segment. So this is as simple. This diagram shows how to use an endobronchial blocker. So ये ET tube है and this ET tube is connected to a 3-way conduit. So through one of the channels we pass the bronchoscope. Through another we pass the endobronchial blocker. We hook the string, the latch of the endobronchial blocker at the tip of the bronchoscope. Then we pass the endobronchial blocker and the bronchoscope. We guide it to our desired segment. Once we have reached into the desired segment, we again loosen the knot and we remove the bronchoscope and inflate the balloon at the tip of this endobronchial blocker. And after inflating, it looks something like this. So an alternative to Fogarty catheter is a glue injection. So this is a cyanoacrylate glue and it is liquid when inside the vial. What we do the bronchoscopy, reach the desired segment, we pass a catheter through the bronchoscope, and once we have reached the bleeding segment, we inject the cyanoacrylate glue inside the bleeding segment, and once the glue comes in contact with the mucosa, it solidifies and forms a clot, something like this, and closes the bleeding segment. That's one way of controlling the bleeding. Sometimes the bronchoscopy may not show any active bleeding, but you might see a clot, something like this, which is impairing the ventilation. So if you're not able to suction this out through your bronchoscopy, what you can do, you can pass a cryoprobe, which looks something like this. The tip of the cryoprobe freezes. So once you have passed the cryoprobe, you have to apply the tip at the clot. The cryoprobe tip will freeze and the clot will get adhered to the cryoprobe. Then you can remove the entire thing in toto. So in this diagram we see that there is a bronchoscope, there is a cryoprobe passed through the suction channel, and the clot is attached to the tip of the cryoprobe. The bronchoscopy may also show you something like an endobronchial tumor. So if this tumor is bleeding, what you can do, again, pass the bronchoscope. Through the bronchoscope you can pass a catheter, the cautery catheter or the APC catheter, and burn the source of bleeding, burn the bleeding vessel. So that's one way of controlling the hemoptysis. So these were the methods that you can employ through a bronchoscope and control hemoptysis. And all of this can be done while the patient is having active hemoptysis bedside. So this tool of bronchoscopy and scale of bronchoscopy comes very handy when you are managing a case of massive hemoptysis. Now, role of contrast enhanced CT scan. So I want you to focus on the word contrast. Whenever you are dealing with a patient of hemoptysis, always use the contrast CT chest and not NCCT or HRCT, because contrast helps you to identify vascular lesions like aneurysm. So obviously it is superior than chest X-ray for detection of parenchymal abnormalities and is better for localization. So a small mass, bronchiectasis, these are the things that you can pick up on CT much more commonly. But for CT you need a stable patient. There should be no active hemoptysis ongoing. And as we discussed, that it can help you identify the parenchymal abnormalities. And suppose you are dealing with a patient who has got mild or moderate hemoptysis, and you do a CT chest and you find something like bronchiectasis or tuberculosis or tubercular cavity or an aneurysm. So a CT chest beforehand in a stable patient can obviate the need for flexible bronchoscopy. So you have the cause, your patient is not actively bleeding, you don't need to do a bronchoscopy. It can also help you suggest future interventional or surgical decisions, and we'll see how. So CT chest can show you parenchymal lesions. So if you find a localized bronchiectasis, you may take a surgery call and get the lobe removed. It may show you an aneurysm, such as in this case where you need to do coiling, take a interventional radiology referral. So now in this CT we can see a soft tissue inside the left main bronchus. On a bronchoscopy we find a polypoidal growth inside the left main bronchus, and this you can debulk, remove by snaring or coring under rigid bronchoscopy. The CT may also show you an aspergilloma cavity, and for which a surgical reference can be taken and the lobe can be removed. The CT can show you something like a Rasmussen's aneurysm. So this is TB, post-TB fibrocavitary disease, and there is a pulmonary artery aneurysm, such as in this case and in this case. So in such cases you have to take IR call and get coiling done. Now suppose if the hemoptysis is refractory to the temporary measures that you have done by bronchoscopy, or there is repeated hemoptysis, what you can do is you can do a bronchial artery angiography and embolization of the culprit vessel. So in the previous lecture we saw that most of the reason of massive hemoptysis is because of bronchial artery involvement, because it's a high pressure system. So in case of refractory bleeding, you are going to first focus on the bronchial artery, do a bronchial artery angiography. Such as in this case, there is a right upper lobe fibrocavitary disease and the patient has undergone CTBA, and it shows an abnormal tortuous artery originating from the aorta and forming multiple tortuous collaterals. The patient underwent bronchial artery embolization, and post procedure there is complete occlusion of these tortuous vessels, as we can see in this diagram, and that's how we can control hemoptysis. This is a rigid bronchoscope. It's a long hollow metallic tube that you can put inside the airway. For this, again, this is done in general anesthesia. So you need a relatively stable patient. You need OT, and it is done under general anesthesia. So what is the advantage when we need to do a rigid bronchoscopy? Okay, so if on flexible bronchoscopy we have seen that there is a tumor that needs debulking or laser or APC therapy, or there is a clot which is not getting removed by flexible bronchoscopy. So these are the situations when we might need a rigid bronchoscopy, particularly for tumor debulking and tumor removal. So what are the advantages of rigid bronchoscopy? First, it gives you definite airway. It also gives you a greater suction capacity and superior visualization. And obviously, when you do a rigid bronchoscopy, you can pass a flexible bronchoscopy through it, and the both can be combined as per the patient need. Now, role of surgery. So as we saw in, for example, post-TB cavity or localized disease such as a localized carcinoid or localized bronchiectasis, you may need to remove the lobe for permanent treatment. But when it is done in emergency setting, it has got a high mortality rate. So surgery should be something that you should plan electively, because in the emergency setting it has got a high mortality rate. So let's summarize everything that we have learned in this video about management of hemoptysis in one slide, and this is the most important slide of this entire presentation. So your patient presents with life-threatening or massive hemoptysis. You assess for the vital signs and do a chest X-ray to identify the potential bleeding source. If the vital signs are not stable, you intubate the patient, correct the bleeding abnormalities, and position the patient with bleeding side down. If your patient is still not stabilized, you go forward with a flexible bronchoscopy to localize the bleeding source and reduce the bleeding by putting saline, ice saline, adrenaline, or using a balloon blocker such as a Fogarty catheter or an endobronchial blocker. Now, has your patient stabilized? If not, then continue supportive care, and you may do a balloon tamponade, again by using a endobronchial blocker. Now going to the second scenario, where the patient has presented with hemoptysis and the vitals are stable. You have some time to do a CT scan, and there you go for the contrast enhanced CT chest, and you ask yourself whether the bleeding source is localized. If no, then again you have to go back to flexible bronchoscopy, because if there is nothing on the parenchyma, you may find something inside the airway. If your CT scan shows a source of bleeding, then you may go forward with thoracic aortogram followed by selective bronchial and systemic angiography. And once you identify the bleeding source, then whether it is amenable to embolization or not, that you have to discuss with your IR team. If it is amenable to embolization, you embolize the culprit vessel. If you don't find any cause on CT bronchial angiography, you go forward with pulmonary angiography, and you find a bleeding source, then embolize the bleeding source. If the patient has rebleeding, then you have to go forward with something like endovascular embolization again, or refer for surgery for definitive treatment. Thank you for being with me till the end of this video. Subscribe the channel and follow to be updated with more such clinical discussions. See you in next video.